As most everyone is certainly aware, CPAP has the mainstay of sleep apnea therapy, but not everyone is able to tolerate it. And historically, a lot of our surgeries have been less than effective and fairly high morbidity. It's been very exciting to have a therapy that's actually a little bit more effective and less morbid for patients. And I think through this discussion, you'll see that it's a quite a safe outpatient procedure with fairly low morbidity. There's three components and a sleep remote, and the patient has complete control of it. And particularly important is the ability to monitor use, much like you would with CPAP and smart cards in current machines. You can see how the patient is doing as far as utilization and get some feedback in that realm. Over the last 5-6 years since the STAR trial and the FDA approval, there's been quite a large number of publications with pretty high quality data, certainly relative to what we've seen in other sleep surgeries. And with that, we've seen significant advances in insurance coverage, recognizing the validity of the data and the efficacy that we see with it, to the point that most private insurers cover the therapy, Medicare, and then the VA is adopted it as well. It's just a little bit of background information. The STAR trial was done essentially as the FDA approval about 5 years ago. I guess maybe a little bit longer, 6 maybe at this point. But you can see that what it showed was moderate to severe sleep apnea of around AHI of 30, and significant improvement. Interestingly, it seemed to not only give good benefit at a year, but it persisted, which, as many of you probably know, with some of our other surgeries, that's another significant issue. Even if we get a great result at a year, by 5 years, many patients who have a palate surgery are already having symptoms again. As far as the AHI and objective measures, we have good improvement there. But what's important to patients, of course, in addition to that, is their symptoms. So, the Epworth Sleepiness Score that normalized in pretty much all of the patients in that trial. Since that time, there has been an additional push to capture data of patients in more of a real world setting, not just centers of research that were using the STAR trial, but a much larger cohort of patients, and that's the ADHERE registry. And what we've seen are very comparable results, in some cases even better, I think, and with a much larger number of surgeons. So we're seeing that it's something that is definitely reproducible. In addition to the overall AHI improvement, other things that I think are pretty remarkable, honestly, are the number that we see down into the normal range. 5 and under, and even 10 and under is pretty significant. And the same sort of improvements in the Epworth sleepiness scores are seen in this trial as well, or this registry rather. The other things that are very significant, patients do very well with it. It's something that satisfaction is quite high, and I think that is reflected by not only their comments on it, but the adherence. We're seeing around 6 hours a night of usage, and I think in many patients it's the entire night. It's not something that is typically discontinued once they are using it. So just a little bit on the high level function of the device. You can see the remote there that the patient turns it on when they go to sleep. 3 components: a sensing lead in the chest coordinates the stimulation with the breathing. The generator, which is essentially a pacemaker-like device, it's the brains and the battery of the device. And then the stimulating lead, it's a hypoglossal stimulator, so it stimulates the tongue, but you'll hear it referred to as upper airway stimulation quite often, and that's because it has a kind of a collateral effect on the epiglottis, which isn't shown here, but the palate as well. These structures are coupled together, and so when the tongue muscle is contracting and pulling forward, as you will see on this video, we get a palatal movement anteriorly as well as the epiglottis. And so I may see 3 or 4 things that are collapsing on a sleep endoscopy, and in the right scenario, I can treat all of them with this device because of the connections that the tongue has to these other structures. Here is a sedated endoscopy video looking at base of tongue collapse in a patient who's spontaneously breathing under propofol sedation. And so that's been shown to be pretty equal as far as the AHI and the most of the major sleep parameters to natural sleep. And with stimulation, you can see this sort of snapping forward of the tongue and the epiglottis coming with it, coordinated with breathing. Probably most importantly, here we see the palate, which is generally a problem in sleep apnea almost across the board, is staying collapsed. And in this video, you can see that same sort of opening at the same intervals with respiration. And so we're seeing opening of the airway at all 3 of these levels. As far as the patient's pathway to getting this therapy, there's screening, making sure that first they have the diagnosis of sleep apnea, they're tried on CPAP, and we do everything we can to exhaust that option. And if that is the case, patients will generally proceed to a sleep endoscopy. In my practice, whether we're looking at Inspire or another option, just because of the objective information about the levels of collapse. Once that is done, if they're a good candidate there, then go through the insurance channels and subsequently the procedure. The device is tested and left off for about 3 to 4 weeks, and then it's activated during the day at a visit in our institution at the sleep lab. And the device is given rough parameters for at the low end muscle effect and at the high end patient comfort, and the patient will move through that as they spend time getting acclimated to the therapy over the next month or so. And then they'll have a sleep study for titration, much the same as you would for CPAP. And then there's long-term follow-up that we'll talk about more later. The eligibility requirements, the age was dropped to 18 recently. So it's essentially for adults. The AHI range is quite broad, 15 to 65. That's what the data allowed insurance to approve, or the FDA to approve. And so some insurance follows that more strictly. Certainly CPAP failure or intolerance. And then importantly, the sleep endoscopy airway collapse, particularly at the palate, which I'll show you in just a second, it needs to have no circular collapse, which will make more sense when we look at the video in a moment. And then this percentage of central and mixed apnea needs to be 25% and under. BMI is something that was important in the STAR trial. They looked at patients with a BMI of 32 and under, and the FDA didn't specifically put that in the approval. And some insurance has taken a slightly higher BMI of 35 based on data that's been put out since the STAR trial. Others are pretty strict at 32, and the benefit, I think, really comes down to what we see at the sleep endoscopy, and the chance of the circular collapse that is makes someone not a candidate increases as the BMI increases. So that's just something that we have to look at on a case-by-case basis based on the insurance. So once the device is in, as I said, we test it and then turn it off, and then it is activated. And that is essentially setting a rough range that the patient can get acclimated to the therapy.
You can see the physician ask the
And
patient
here's a
to
short
go
video
supine for
about
this
that
visit.
process.
You can see the telemetry wand here placed over the device. That allows the physician to use the programmer to communicate with the patient. And all the physician did there was find the amplitude, which provided effective and comfortable settings.
So in that video, um, you know, the speaker mentioned, you know, the physician doing the programming, and in some places, the implanting surgeon is also doing the sleep titrations, and in others, it's sleep medicine, and even in some of those practices, it's the sleep techs and you know, physician extenders that can do a lot of this as well once you know, once they become comfortable with it. So all of the advanced titration that we're talking about is a software adjustment. They don't need more surgery for that. You know, these parameters that are listed over here can all be adjusted just with the programmer. And in particular, the electrode configuration, as you can see on the slide to the, or the picture to the right, the cuff of the electrode actually has 3 small electrodes, and the polarity can be switched around, turned off, things like that, to get, you know, 5 different configurations. And in the general setting is usually adequate for 80-90% of patients, or the default setting, I should say. But if it's not, we have quite a bit of variability to change things to improve the efficacy and comfort of the therapy without, you know, any sort of invasive procedure for the patient. The things that are very valuable and beneficial about upper airway stimulation, it's almost certainly the most effective procedure that we have, you know, after CPAP failure, and there's no question it's the lowest morbidity. You know, it's something that patients just tolerate extremely well. For both of those reasons, patients ask about it all the time. You know, I'd say half the patients I see come in on their own without being referred by a sleep medicine or other ENT, because they, you know, they're suffering, and so they need therapy, and they are not so inclined sometimes to have the more invasive surgeries, and so they're going to come and ask about it. And I see quite a significant improvement in or increase in patient volume for that reason. And similarly, patient satisfaction. You know, there's very few things that are as frustrating as not having any sort of an answer to, or any means to help somebody that comes to you for help. And so having another tool, particularly an effective tool, is quite nice. And it's not very much different from the sleep medicine side to what's already done. It's different than, you know, adjusting pressures on a CPAP, but you're just adjusting the amplitude of the signal, but the overall, you know, means and what you're looking at is not much different. So, you know, every sleep lab is more or less set up to start doing this fairly easily.